So we're going to start with the first talk by Dr. Anand VINEKAR. He needs no introduction. The amount of work he has done in Ryan Nethralaya, Bangalore, and he's especially his KidROP program. So he's today going to talk to us on anti-VEGF in ROP. Dr. Anand, please.
Thank you, sir. This is a rather vast topic, so I'm just going to make it a little clinical and not delve into most of the controversies which will be talked about in another talk. I think almost all our data has come from these prospective studies of the beta ROP, the rainbow, its follow-up, and the butterfly and flyify, depending on which drug. I'm just going to summarize here what we believe in India where we are using this drug. We are using it in aggressive ROP, the hybrid forms, zone 1, type 1 ROP in zone 1. If the pupil is rigid, if there's vitreous haze, there's NVI, there's tunica vasculosa. If you don't have laser, you don't have expertise to do laser, or you don't see adequate regression after laser, and sometimes intra-op or pre-op with vitrectomy. Possible relative contraindications would include if there's already a detachment, a stage 4 or 5, there's a crunch expected, and of course periocular infections. It is said to be relatively easier to do than laser, a faster regression. Maybe a critically ill child can be treated much better. However, the advantages of possible reduction in refractive errors has now been questioned in this network meta-analysis. It's not that it doesn't have a better advantage, but the more cumbersome difficulty in doing laser was because elsewhere at least it's done under general anesthesia, but most of us in India do it quite well under topical. Also, lower doses can reduce the amount of persistent avascular retina, but lower doses will mean that you have to get in with the second treatment with laser much earlier. The advantage of reduction in myopia has, as I said, been questioned now, and it's not really a very big advantage if the laser is done on time and correctly. How do you assess that your drug is working? So the first important thing is, of course, the media clarity. We don't give it much importance. The pupillary dilatation, the TVL regressing, and of course then the features of ROP, aggressive ROP coming down. Failure, we don't name anything a failure at least until the first 2 weeks, and if there's worsening or if there's no improvement at all. Let me illustrate with a few cases. So this is a very classical posterior zone 1, or what we call a zone half in India. It does very well with anti-VEGF. This one's an example with us giving ranibizumab, and in 11 days you can see it reducing, but in about 40 days, so that's another 3 weeks from there, you see reactivation. Point here is the reactivation after ranibizumab is much earlier and more severe than the bevacizumab, as we have seen in publications and all in the collective experience of the Indian ROP Society members. And then, of course, one must laser. If you have the facility to do an angiogram, it really helps to pick up where those loops, those CNPs are. It's really important to add in a few more rows of laser into that area, because that is also ischemic and will not regress. Now, this was a baby who was injected elsewhere, and we don't believe this was crunch because they have documented that it was already detached when they gave the drug. But the point here is, look what it has done to the vessels. The vessels have not even come out of the traction, and this is like a complete occlusion. Nowhere, even in zone half, has this been vascularized. So what did we do? We waited for a little while, for about 4 weeks, 3 to 4 weeks, weekly visits, and this child came from another state, and within another 3 weeks, you can see the recurrence. Unfortunately, this recurrence was in zone 1. So we did a macular sparing laser. Not that we expected the detachment to go away, but you can see the exudative component going away, and this child held on for many more months and had some useful vision. In another case, you can see this is the occlusive vasculitic form of aggressive ROP against zone half. This is a late vitreous hemorrhage that we noticed about 4 days. We have a day 1, then we have a day 4, and the hemorrhage came in much later. But along with this hemorrhage, you can see a lot of exudation. So this looked a little worrisome, but since it was too early to intervene to do anything else, we just followed up, and of course we planned this baby for surgery if required. But just short of saying miraculously, the exudation comes down as the heme reduces, and this is the same eye followed another few weeks later when the vessels go up till the end. An angiogram confirms no recurrence, only a persistent avascular retina, and does very well with laser. So I think angiography is a very important tool, although not essential, and there have been patterns along with AV shunts and popcorns and so on. I'm going to move a little faster now. So persistent avascular retina is some is something that you can see, and we wait for these babies to at least become 4.5 kgs, but it would depend on the surgeon's convenience of comfort of doing laser under topical anesthesia. And let's follow each eye separately. So this is an occluded vasculitic subtype. The point in this case is to show you that recurrences don't happen symmetrically in both eyes. You can look at the right eye, it's still growing very well. The left eye has actually shown a stage 3, possibly an early stage 4A. So what do? We laser only the left eye, and we follow up the right eye on its own merit, like the same way we wait for 4.5 kgs, we do an angiogram, and we only treat the PAR. What's important is one must have believed that if you do a very posterior laser like in the left eye, you might have more myopia. But just goes to show you that the myopia was almost equal in both eyes even after 1 year of follow-up. So this is something that we must realize, that just because we're doing more laser posteriorly, it's not always more myopia. This was developmental pediatricians and neonatologists looked at a systematic review for neurodevelopmental impairment and found that anti-VEGF does have more chances of neurodevelopmental impairment than laser. And combining it with laser, anti-VEGF combined with laser, what we talked about, combined therapy, will reduce that detrimental effect than giving twice injections. So it's really important. It's not that anti-VEGF doesn't work. One must know when to use it, and don't just do it because it's easier. This is some publication from our society showing you where the society members are using it. Still, the drug of choice has remained and is possibly changing now from bevacizumab to ranibizumab. We use half or 1/3 of the dose, and this is our follow-up. This is a more recent publication from the group, which shows that, and probably over 10,000 eyes, which shows you that these babies can be injected on the same day. And this is against possible conventional wisdom of adults, where we don't do both eyes on the same day. And this is a paper written out by Dr. Dogara and myself, where we looked at all the existing literature in India and said, how can we summarize the anti-VEGF use for India and middle-income countries? So we still advocated under topical anesthesia. We don't recommend simultaneous anti-VEGF and laser. The follow-up, as we said, weekly for the first 4 weeks, 2 weekly after that. Wait for the weight of about 4.5 kgs. This is assuming there's no recurrence. And eventually, and the National Neonatology Forum recommends a follow-up of up to 60 to 65 weeks. The real important thing here is to look for that persistent avascular retina. This is from the screenshot of the National Neonatology Forum. Your neonatologists are expecting you to follow up these babies as late as 60, 65 weeks. This was 7 important points that we can look at for when to do laser after the injection. So the response to the drug, and we defined what failure and good regression is. If there's recurrence, move in earlier. At least try to wait for the growth to enter zone 2, and the weight of the baby. If you're not comfortable lasering a baby 3.5 kgs, then intervene earlier if it means so. Or if you're more comfortable or you have the facility for general anesthesia, then you can wait longer. And systemic conditions, so important: anemia, thrombocytopenia, and so on. And follow-up compliance, especially as our babies come from the rural areas. This is something we must be very aware of, that if we keep asking them to come weekly, or even 2 weekly for that matter, at some point of time we're going to lose them. And at that point of time, it's possibly better to laser and let them go into the community than completely miss them out and expect late detachments. Because as literature has shown, these detachments can happen as late as 3, 5, and we've seen even 10 years after injection. This is a summary of what will eventually come out, possibly with minor modifications from the Indian ROP Society. We recommend different follow-up schedules depending on the drug used. We don't have collectively as much experience with aflibercept, but these are the 2 important drugs that we're using. The reason why we would want more frequent follow-ups in ranibizumab, as I showed you in that example, the recurrences are earlier and more severe than bevacizumab. And these are only criteria that you can modify based on your comfort. But the main reason why we gave anti-VEGF and didn't do laser in the first place was because we did not want to do extensive laser into the macula. So if you're not waiting for some vascularization to proceed at least beyond zone 1, we've defeated our own purpose. So at least wait for the vessels to get into zone 2 posterior or zone 2A, unless, and we saw the examples, or based on your comfort of the weight, and if you have GA facilities, that's different, but eventually that's what we want to do. Thank you so much.